Hello, Amanda. My name is Eric.
Hi.
I'm your husband and also the nurse practitioner that will be assessing you today.
Okay.
Why don't you have a seat for me? I'll be doing a chest and thorax examination because this isn't weird at all for my Unit 4 in nursing practitioner school. What I'm going to be doing is checking out your chest, your breathing, your lungs, as well as your heart, so that my professor knows that I know how to do this examination when I'm a real nurse practitioner a couple of years from now.
Okay.
Sound good? Do you have any questions for me, any concerns before we get started?
No.
Okay. All right, what I'm going to get started with is just letting you know I've got some equipment here. I have my stethoscope, a pen light, a pencil, as well as a measuring card. I'm not entirely sure why we're using this in real life, but here we are. What I want to get kind of started with is to ask you, Amanda, do you have any cardiac or pulmonary, that means lung history?
No.
No. Anything in your family, any concerns, any medication or anything like that?
No.
Related to this in any way? I do understand you had some PACs previously and a 12 lead diagnosed.
Correct.
Correct. But nothing diagnostic, no issues with that as far as you or your doctors can tell.
Right.
Is that right? Okay, so no heart murmurs or anything like that.
No.
Okay, so we want to always establish the medical history of the patient and any concerns that they might have kind of going into things. What I'm going to start with while she's upright, I'm sorry, I'm going to be talking about you and about this thing as I go through this. You're welcome to smile at the camera because this is kind of a weird thing that we're doing here. Am I right? Just to say that she's in no obvious respiratory distress. There's no obvious cyanosis. If I could take a look at your fingers just briefly on both sides here. Yeah, there's no clubbing, no cyanosis of the fingertips or anything like that. Do you like this for me? A bit strange, I understand, but yeah, no cyanosis or any pallor of the lips there or anything like that. Her skin, her thorax all look good. Do you have any kind of scars or bruising on your abdomen or your chest specifically that you'd like me to assess today? Any concerns you have like that? No. No, excuse me, history of surgeries on your lungs or your heart or anything related to that as far as you're aware? No. Very good. Okay. Her posture is also very good. I can tell just from talking with her and speaking with her right now that her respiratory pattern is equal. Bilateral chest rise and fall is totally normal. I'm going to begin with a series of examinations. I'm going to be palpating. That means to touch. Percussing, which is the tapping of the thumbs to hear kind of the percussive sounds of things, as well as auscultating, which means listening very closely with my stethoscope. At some point, I'm going to have you lay down as well on your back. I probably am going to have you twist around as well so I can see your back very well during this examination. Are you comfortable with all of that?
Mm-hmm.
I will not have to undress you in any way. I will be at the end of this describing how I would do a breast examination on you, but I will not actually be filming that as well. Are you comfortable with all of this before we go ahead? Okay, very good. Thank you, wifey. Mm-hmm. So to begin with, do you have any tenderness of your chest or your thorax, your back, as we call it here when I'm touching you?
Mm-mm.
Any discomfort or anything like that? Okay. Any pain or discomfort when you're breathing deeply?
No.
And no difficulty breathing in or out in any way, shape, or form? No. Very good. Thank you. I noticed that there is symmetrical rise and fall again of the chest when she takes a deep breath. I want to start with what we call a tactile phrematus exam. So if I could have you turn around, just like I said, 180 degrees. Your feet are going to be on that side of the bed. What I'm going to be doing is touching you with the back side of my hands, kind of in a judo chop fashion. I'm going to kneel down here. Hopefully you can still see me in the video. Take a deep breath in and out. Breath in and out for me. All right. And this time I want you to say 99.
99.
Again.
99.
One more time.
99.
All right. And one last time.
99.
It feels equal on both sides. And the next thing I want you to do for me is take a deep breath in and out. I'm going to feel how well your chest wall expands. So there's about 2 to 3 centimeters of expansion there. One more time for me. Yeah, again about 2 to 3 centimeters. I understand you have a very tight-fitting bra on, so that can kind of tighten things up a little bit. I do want to check for your brachial pulses here. So if you'll excuse me real briefly. Strong brachial and radial pulse on the right. Strong brachial pulse and radial pulse on the left as well. Any discomfort so far? Okay, very good. I'm going to start with percussion. So what we want to hear is a nice deep kind of hollow thud sound, as we would expect from lung spaces because they're filled with air, right? And you can just breathe normally through this. You kind of feel how it's different there at the very bottom? Yeah, because below the diaphragm it gets very dense, right? So what I'm going to actually do now is I'm going to tell the difference between your full inhale and your full exhale, where that point is, okay? I'm going to measure that difference. So take a deep breath in and hold it for me. Right around there. Okay, and now breathe normal for me. I'm going to mark that kind of point with my finger here. Breathe normal for a moment. And when you're ready, take a deep breath in and fully exhale for me. Very good. Okay, you can breathe normal again. That is about 1 centimeter of difference, which is perfectly normal for a person at your age. Thank you so very much. Okay, the next thing I would like you to do, go ahead and turn around for me. I'm going to do basically the same exact thing on the front side here. I'm going to be oscillating again and percussing again here, so it's a bit strange. Probably a bit more intense than what your doctor normally does, right? Okay, everything sounds totally equal and normal there. I know I'm getting quite intimate with you here, but this is how we practitioners do at the very onset of diagnosis. I appreciate that so very much. The next thing I want to do is take a listen to everything, just like we were doing, okay? This time you shouldn't have to turn around at all. I can scooch around the back if I need to. If I have to lift up your shirt, I'll let you know before I do it, okay?
Okay.
And I apologize if the stethoscope is kind of cold. I'm going to get the bell side ready here. Start things off with the posterior examination. Just breathe normally for me. Everything sounds good posteriorly. I'm going to take a listen on the front side as well, all right? We have good vesicular lung sounds bilaterally. Underneath the breast, the deep lung sounds. more equal bilaterally. There's no obvious consolidation. Sorry, I'm going to talk into the camera for a moment. There's no obvious consolidation or hypo or hyperresonance or anything concerning to me in any way, shape, or form. I'm going to take a quick listen to your the sounds, of your heart in your carotid arteries as well as your heart sounds here now. So no abnormal bruits or thrills on either of those. Normal S1, normal S2. I am hearing a bit of an early S1 kick, as previously noted with PACs. It's not regular, but every so often I hear an early contraction. There is no obvious S3 or S4 and any galloping sounds or anything like that. The heart sounds are all totally normal as far as I can hear so far. Okay, if you go ahead and lay down for me now, please. What I'm going to do next is a bit more in-depth. I'm going to again listen to the heart sounds. So what I'm going to have you do is take a breath, just a regular breath, and hold it for me so I can listen a bit closely. I'm also going to look at any kind of jugular venous distension. We call it JVD. I'm going to try to locate the point of maximal impulse, the PMI is what we called, of the heart, to try to find where it's beating the hardest. Okay, any questions, any concerns going ahead so far? We doing good?
Yep.
Okay, I know it's a bit longer and a bit more involved and intense than you normally would have with your doctor, but you're doing great so far. Thank you so much for letting me do this.
That's why NPs are the best.
Thank you. So again, with the carotid pulses, what I'm actually going to do, I'm going to palpate them really quick, one at a time. Very strong carotid pulse on the right. And it's equal on the left. We don't want to do both at the same time. We can make you a bit dizzy with that, so we're not going to do that at all, definitely. Bear with me one moment. I'm going to try to take a good listen to that heart here. And go down to the first, second, third, fourth, approximately the fifth intercostal space, and locate the point of maximum impulse. Again, everything sounds very good. It all looks equal and normal bilaterally. Your heart is beating just as it should be. Next thing I'm going to do is what's called jugular venous distension assessment. So it's going to be a bit odd. I would like you to look to your left a little bit if you could, please. Use an oblique light here. Pick out where the jugular vein is as opposed to the carotid artery. I cannot visualize, if you can't see that on the camera, I cannot visualize any obvious distension. There is no clear or marked rise above the regular tension of the skin. If I were to take a piece of paper, excuse me, above the mid-clavicular line at the angle of the sternum and measure it, would probably get about 2 centimeters at the absolute most, 1.5. But of course, Amanda here has excellent cardiac function, no concerns and no problems that she has ever noted. I can help you up here. Thank you so very much. That concludes my assessment this time. I would have to say you have absolutely excellent cardiovascular and respiratory function. Do you have any questions or concerns for me?
No.
Okay, thank you very much.
Thank you.
Thank you, doctor.